Welcome to the fifth in the series of presentations on spinal radiography. The intent of this presentation is to provide description and examples of additional spinal disorders encountered in small animal practice. And those additional disorders we'll speak about include spinal trauma, spinal infection, specifically discospondilitis, and spinal neoplasia. Let's start with spinal trauma. Spinal trauma is frequently encountered in veterinary patients, and trauma identified may include fractures, subluxations or luxations, and traumatic intervertebral disc herniation. We're going to use the catch-all term of spinal fracture luxation as our conclusion after we have thoroughly described abnormalities, as we don't always identify all of the trauma. So again, you will hear me talk about the conclusion of spinal fracture luxation. One thing to keep in mind is to always evaluate the spine critically in trauma cases, even when you're just radiographing the thorax or abdomen, because we can oftentimes identify spinal trauma. These patients may be shocky, you may not be able to do an adequate neurologic exam, and so it's really important to not forget about osseous trauma, including spinal trauma. So this patient, I have a lateral radiograph of the thorax in a patient that was hit by a car, and the thoracic radiographs were obtained to assess for thoracic trauma, which this patient has. There's some pneumothorax. We can see the air opacity in the pleural space and lung lobe retraction, and then a combination of some free pleural air and some pleural effusion. But when we look really critically, because we're systematic and we evaluate all parts of the patient, as we scan through our thoracic spine and move caudally using our systematic approach, we can see that there is actually a problem here at the L1-2 kind of intervertebral disc space. This image on the right is just a zoomed image of the regular thoracic radiograph. And what we'll notice is that L2 here is dorsally luxated with no longer any articulation between those articular processes. And then that intervertebral disc space is also collapsed, so likely there's traumatic herniation. So again, we're going to say that this patient has a spinal fracture luxation at L1-2. Radiographic findings of trauma can include malalignment of the spine, widening of the articular process joints, changes in width of the intervertebral disc space, which may be collapse and narrowing, but may also be widening or distraction, certainly osseous fractures, and then also we need to look for regional soft tissue changes, so paraspinal changes, but also into the abdomen and the thorax. So in this lateral view of this patient, you can see that L6 and 7 are definitely ventrally located relative to the rest of the lumbar spine. The articular process joint is completely luxated on both sides. And then there's some severe narrowing of that intervertebral disc space. This patient also has some retroperitoneal soft tissue swelling that may be a combination of hemorrhage and even potentially urine. So it's not uncommon if you have caudal abdominal trauma that we may have distal ureteral trauma, or remember that the urethra is partially enveloped by a reflection of that retroperitoneal space. So urethral tears can lead to peritoneal retroperitoneal urine accumulation. Here's a lateral view of a patient that also was hit by a car. When we're evaluating, this one was specifically taken for the spine, and when we're evaluating the spine, we can see that there is malalignment, where L1 is dorsally luxated or dorsally located relative to T13. The caudal articular processes no longer contact the cranial articular processes, so that's completely luxated. When we look really critically, we can see that there is actually a small osseous fragment ventral to the L1 body, which is probably coming from this little lucent area on the corner of the cranioventral aspect of the body of L1. Now you need to be systematic and look at everything. So although we're specifically imaging the spine here, we want to look at the regional soft tissues. And in this patient, we can actually see the lung lobes are retracted with some gas in the pleural space around them. So that's a little bit of pneumothorax. And then there's a fairly significant unstructured interstitial pattern, maybe almost alveolar pattern in the caudodorsal lung lobes here that would be consistent with pulmonary contusion. We would also want to evaluate the retroperitoneal space as much as possible and the peritoneal space. Remember when we talked about technique, in these patients, especially if you're really concerned about fracture and luxation, we won't routinely right away obtain that orthogonal view. And so the examples here I have shown you only had the lateral views. We evaluated them, identified the lesion, and then did not take the orthogonal view. Here's a patient where they did obtain orthogonal views of the cervical spine. I don't remember what the trauma was on this patient, but it had neck pain. Probably the lateral view shows this the best. We can see that there is a little separate osseous fragment here that appears to be similar in size to what looks like a lucent defect in the caudal body of C3. Notice that there's also narrowing of the intervertebral disc space between C3 and C4, and also it looks like C4 is slightly ventral when we look at this ventral aspect of the vertebral canal. It's slightly ventral with a little step from the vertebral canal over C3. On the ventrodorsal view, I actually am not going to be able to identify that trauma very well. Other than that, I can see that the intervertebral disc space is again narrowed. So this patient has a spinal fracture luxation that also likely has traumatic intervertebral disc associated with it. Here's an example of a puppy. Notice that we still have some open physes at the vertebral end plates. A puppy that was hit by a car. And on the lateral view, probably what I see easiest is that L5 and L6 are ventrally located relative to the cranial lumbar spine. And then if I look at the articular processes, again, there's complete luxation with no kind of joint space overlap here. Then if we evaluate L5, there is this lucent kind of defect area, and then there is this separate osseous portion that is a fracture that is off that kind of caudal and mid-body of L5. Notice that this has kind of overlapped or compressed together. So this patient has a fracture and luxation, with the luxation at L5-6 and the fracture involving the body of L5. They did obtain an orthogonal view on this patient, and on the orthogonal view, a lot of the trauma is not identified. Notice the alignment doesn't seem to be all that off, but what I do notice is that this L5 vertebra is much shorter than L4 and L6. And so at least on this part, it looks like there's a compression fracture, which then we can get a little bit more information from our lateral view. On this patient, we also have orthogonal views of the caudal lumbar spine. And when I assess this patient, this one's a little bit more challenging, I think, to see the abnormality as we're doing our 3-pass method through our spine. What I notice is that the sacrum, the body, and the kind of dorsal lamina, that is ventrally located relative to L7. So if we look, here's our dorsal lamina of L7, and that should line up with this dorsal lamina of the sacrum, but it's actually ventrally displaced. That is because there is complete luxation at the L7-S1 articular processes. When I continue evaluation, I see that just cranial to the body of the sacrum, there is this triangular fragment here of bone that actually is arising from this kind of lucent defect in the caudal body of L7. This is actually the intervertebral disc space at L7-S1, and then there's a little bit of spondylosis at that disc space too. So we have had a caudal body fracture of L7 with complete luxation of the LS articular processes there. Not forgetting to look at everything, when I evaluate this caudal retroperitoneal space, I can see that there is loss of detail with increased soft tissue opacity, kind of this streaky soft tissue opacity that's mixing in with that retroperitoneal fat. And so this is retroperitoneal effusion. And again, our major differentials when we have a fracture luxation of the spine are retroperitoneal hemorrhage and or potentially retroperitoneal urine. This patient has some other degenerative changes that you probably saw, and that is spondylosis at these sites, and then probably even a little bit of osteoarthritis. Now, on the orthogonal view on this patient, if we look critically, we can see some of the trauma. If we look at L7, again, L7, that body looks shorter compared to L6, which, it looks like it's about the same size on the lateral view. And what I can see is this radiolucent line that is over on the left side here, where we have this segment that is separate from the rest of L7. So we have a little bit of left lateral displacement as well. Keep in mind that radiographs can be fairly insensitive for all of the trauma that we might see, especially some of the smaller fractures. And so these are patients that if we need more information for treatment planning, we're going to need to follow up with either a CT to really assess the osseous structures, if that is our most important thing to assess, or potentially an MRI if we need to assess all the trauma that has happened to the nervous tissue. Next, I'd like to talk a little bit about infection of the spine. And as we've already learned in our other musculoskeletal lectures, we've talked about what infection might look like. Infection of the vertebrae can have very similar radiographic signs, so we can have varying proliferation and lysis. I want to speak specifically about discospondylitis, which is an infection that actually begins in the intervertebral disc, and then that infection spreads to the regional soft tissues and the adjacent vertebral end plates. So the osteomyelitis is affecting the end plates, but because it starts in the intervertebral disc, we're going to call it discospondylitis. Generally, this occurs by a hematogenous route of infection, and very commonly secondary to urogenital infections. Because it's hematogenous, we may have multiple sites of intervertebral discs and end plates involved, and any portion of the spine can be affected. Discospondylitis can occur secondary to, like surgery, iatrogenic, or trauma, or migrating foreign objects. But again, most of the time it is by a hematogenous route of infection. It is important that we need to distinguish discospondylitis from other spinal disorders, many of what we've already talked about. So that's including the lumbosacral disease and instability, intervertebral disc disease and herniation, and then spinal neoplasia, which we'll talk about at the end of the presentation. Radiographic findings of this sort of infection include changes to the size of the intervertebral disc space, and changes to the size may actually start out as being narrowed. Oftentimes juvenile patients with very early infection only exhibit narrowing of the intervertebral disc space, but can also be widening of the intervertebral disc space as more and more lysis occurs. Certainly, in order for me to make this diagnosis, I need to identify lysis of the adjacent end plates, and that lysis again is really affecting kind of the cortex. It's not necessarily a specific pattern of lysis. It's usually kind of indistinct. And then, especially with later infection, we start to get proliferative changes, and those can include sclerosis as well as active periosteal reactions on the vertebrae. This is a lateral view of a patient that has discospondylitis at L1-2, and what I notice is that there's a change in the intervertebral disc space, which is wider than expected, and that is really due to the fact that there is this irregular lysis of the caudal end plate of L1, as well as irregular lysis of the cranial end plate of L2. Compare what the length of the vertebral body should be when you look at L3, and you can see how much lysis has occurred. Around the areas of lysis, we can see more sclerotic bone, so there's some sclerosis, as well as kind of this poorly defined periosteal reaction. Some of it even goes ventrally here. Notice that I said poorly defined, and that's our clinical tip, is that active proliferation has poorly defined margins. Compare that to this chronic benign spondylosis deformans that is at the more caudal intervertebral disc space here, where we have really discrete margins of bone. So this is a little bit more advanced discospondylitis in this patient. Here are orthogonal views of a patient with lumbosacral discospondylitis. And lumbosacral site is actually one of the more common sites where we might actually see this discospondylitis. We have to be sure that we really look critically to distinguish this from lumbosacral disease. In this patient, when I look at the LS junction here, I see that there is this kind of triangular piece of bone missing here in that caudal portion of L7 because there is lysis, so it's a little bit poorly defined lysis. I also see that there is lysis at the cranial end plate of S1. The intervertebral disc space is kind of an unusual shape and is widened at LS. Compare the ends of the bones and the intervertebral disc spaces here at L6-7 and L5-6. There is probably a little bit of irregular proliferation as well as indistinct sclerosis surrounding the areas of lysis. So these are very classic findings of discospondylitis. And this is going to be distinguished from just lumbosacral disease and instability because that process should not have this type of lysis. So that maybe we'd see some spondylosis deformans, maybe we'd see some narrowing of the intervertebral disc space if the disc was herniated, but we are not going to see the lysis and this active kind of proliferation. Notice that on the ventrodorsal view, this is going to be a challenging area to evaluate. We can sometimes see the findings on the ventrodorsal view, although I do think they show up better on the lateral view. But notice we have a lot of gas and fecal matter in the colon and the rectum that's going to be superimposed. So you don't want to confuse your ventrodorsal view superimposition artifact from GI gas and other content with true lysis. So if I see something on the ventrodorsal view that I'm concerned is a lytic process or a proliferative process, I always want to compare it to the lateral view and ensure that I can see some changes and try to make sure that we're not seeing superimposition artifact. Here's a patient that has two sites of discospondylitis. In this patient, they actually are adjacent. When I look at L1-2 here, I have lysis of the caudal end plate of L1 and lysis of the cranial end plate of L2. Similar end plate lysis is occurring at L2-3 as well. And then notice there is poorly defined sclerosis and poorly marginated periosteal proliferation. Now this patient does have some spondylosis deformans that seems a little bit more discrete, so this may have been pre-existing. The intervertebral disc spaces also look a bit narrowed when I compare them to the other lumbar intervertebral disc spaces. In this patient, we can see these abnormalities as well on the ventrodorsal view. Again, I can see some lysis at those end plates at both sites and some sclerosis that's a little bit poorly marginated. Really compare them to what the intervertebral disc spaces are in the rest of the lumbar spine to see those changes. The last one, we wanted to contrast the lumbosacral discospondylitis with lumbosacral disease. In this patient, I would want to be sure that I don't think that these are findings of intervertebral disc herniation. And again, the narrowing might be seen with intervertebral disc herniation, but we're not going to see the lysis of those end plates. In this example, this is a patient that's a little bit earlier in the disease process, so that only one of the vertebrae is truly affected. So if we look at the caudal end plate here of L4, I can see focal lysis and some poorly defined sclerosis and periosteal reaction. And at this time, maybe there's a little bit of sclerosis, but there really isn't any lysis at L5. Typically, you guys are going to identify it on both sides of the intervertebral disc space. Again, in this patient, the osteomyelitis currently is only affecting the more cranial vertebral body. Because discospondylitis can be very challenging to treat, and because it is oftentimes in multiple sites throughout the spine, if you identify discospondylitis in one kind of spinal region, I would recommend that you talk to the client about obtaining radiographs of the other parts of the spine as well, because we would hate to miss the fact that there's discospondylitis elsewhere and start treating and then decide, hey, this part looks like it's healing, and stop treatment when we still have another area that is not. I think that this is one time that you might get by with just doing lateral radiographs and not getting your orthogonal views. I forgot to point out on the orthogonal view of this patient, I can see that lysis at the caudal end plate, but again, some of the gas in the intestinal tract may kind of get in our way. Let's finish out talking about neoplasia of the spine. And neoplasia affecting the spine is very similar to that affecting the appendicular skeleton, that findings we've already talked about. And different types of tumors are going to be similar as well. We can have benign or malignant primary bone tumors. We can have metastatic bone tumors. We can have medullary bone tumors such as multiple myeloma or similar. And we can also have soft tissue tumors that arise from the spinal cord and associated tissues or from the paraspinal tissues. I just have a few different examples of some cases of the different ways that neoplasia can affect the spine. Let's start with primary bone tumors. And remember, you can have both benign and malignant. The radiographic findings will be similar. We spent most of our time on the aggressive or more malignant primary bone tumors. And so we're going to look at our patterns of lysis and proliferation. This is a lateral view of a patient with an osteosarcoma that's affecting C2. If you notice, the dorsal lamina and the spinous process have severe moth-eaten lysis and some amorphous periosteal reaction. The lysis and periosteal reaction extend down into the pedicles and even potentially down into the body. And so this is a very aggressive looking lesion, and we're talking about neoplasia now. So this is very typical of what a primary bone tumor might look like. Of the malignant ones, osteosarcoma and chondrosarcoma are most likely. Since this is an aggressive lesion, certainly fungal osteomyelitis might be also on our differential list. Again, we're not going to be able to tell the difference just by radiographs alone. Metastatic bone tumors oftentimes affect the spine and the ribs, and they will have variable lysis and periosteal reactions depending upon the tumor type of origin. Remember, we discussed that carcinomas, particularly of gynecologic origin, oftentimes like to met to the spine and the ribs. This is an example of a patient where we were taking thoracic radiographs for metastasis evaluation. And if we look, we identified a region of moth-eaten lysis with a little bit of periosteal reaction affecting the spinous process of T3. Pretty severe lysis here affecting this thoracic vertebral body. It's very lucent compared to the one ahead and the one behind. There's also some periosteal reaction along the ventral aspect of that body. And in fact, it's shorter, so there's probably a pathologic compression fracture. And then this rib also has an expansile lesion with lysis and some periosteal reaction. One tumor type to think of that has some classic appearance is multiple myeloma. And so that's really arising from the medullary region. And on radiographs, it classically has purely lytic, so no periosteal reaction, so very lytic, kind of a punched out, more like a geographic area of lysis, potentially a little moth-eaten lysis, and oftentimes round or oval. And then because it's multiple myeloma, it usually affects more than one of the vertebrae. This image has arrows only showing a few of the lesions, but if you look at where the arrows are pointing, I see this round lytic geographic area of lysis. In the body of that same vertebra, I also see another kind of more oval area. As you look, there are many, but here's a larger one here in the spinous process. This spinous process has several. This vertebra has kind of a lamina spinous process as well as a pedicle lesion. And then these lesions can also affect the flat bones and even sometimes the long bones. So this patient also has a lesion in the ilium. We can also have soft tissue tumors of the cord or the nerve roots, and the effects of those soft tissue tumors will depend upon the location of the tumor. Oftentimes we don't see anything on radiographs, but if a cord or a nerve tumor gets large enough, it may actually cause some expansion of the vertebral canal or the foramen. So this is a lateral view of a neck of a dog that has a spinal cord and nerve root tumor. And when we look at the junction here between C5 and C6, there is this oval lucency, which is really expansion of the intervertebral foramen there, and then the canal also is kind of expanded where the dorsal lamina is a little bit more focally and dorsally changed compared to the other dorsal lamina. This is a dorsal plane of the corresponding MRI, and we can see the tumor here as this bright signal kind of bilobed region, and we can see how it's big enough that it could cause that expansion. This patient is a cat, and this patient has a paraspinal soft tissue tumor, and oftentimes those will cause effects on more than one bone. The bone that really sticks out here is L3. There is some moth-eaten lysis and some sclerosis of the body and up into the pedicle. But if I look very critically, I can actually see some changes in the vertebral body of L2 and the cranial aspect of the vertebral body of L4. I believe there's also some poorly defined periosteal reaction here as well. On the orthogonal view, although there is some stool here in the colon that gets in the way, I think the lesion is a little bit more left-sided. Certainly, as we discussed much earlier in a presentation, most of these lesions would require some additional imaging with MRI or CT to fully evaluate the extent. Be sure to consult the textbook chapter and the listed pages here for further explanation and also to get additional examples of these disorders that we just talked about.